So I just have to say that this is the first in-person lecture that I've given in like 3 years. And so it's a little bit nerve-wracking too. I mean, I'm not like normally a nervous person, but we've got to get back into it after COVID. So officially good morning to everyone. And thank you, Jared and the organizers, for inviting me to speak on this topic today. So the human papillomavirus infection causes a huge amount of morbidity and mortality, but remarkably, this can all be prevented by vaccination. So I'm going to take us through today the current situation with regards to HPV infection and its disease manifestations, the national vaccination program, and what the new recommendations and thoughts are on improving prevention of HPV and its related complications. Do I have to press it, or can I use?
Let's see. It might be there.
Oh, it's going to be on there. Okay, cool. All right. So I'm just going to start off with some basics on HPV infection, just to refresh everyone's memories. So HPV belongs to the family Papillomaviridae, and it has over 200 types. So these types can be classified in a few ways, one being on the locations of the body that each virus tends to infect. So for example, cutaneous or mucosal, and then the other way is by their potential to induce cancer. So this is either low risk or high risk. So genital infections are sexually transmitted, and about 70 to 90% of these infections will resolve in 12 months. However, if you have a high risk or carcinogenic HPV infection that persists beyond 12 months, then this increases your risk of progression to invasive carcinoma. And these are the 12 high-risk HPV types associated with cancers in humans. HPV 16 and 18 together are responsible globally for 70% of cases of cervical cancer. And then just to note that it's well established that HIV-positive women have a higher prevalence of persistent HPV infection, risk to progression to high-grade cervical dysplasia, and cervical cancer compared to HIV-negative women. So when thinking about HPV infection in South Africa, we're mostly concerned with the high-risk prevalence. And this ranges from about 37 to 66%. And this figure is based on studies that were done from 2013 to 2019. So our 2017 National Cervical Cancer Prevention and Control Policy posts a prevalence of 54%. HPV was the most common high-risk type in 3 out of 4 of the most recent prevalence studies. And then other than HPV 16 and 18, types 35, 39, 45, 51, 52, 58, and 59 are the other high-risk types that are found quite frequently in our population, which really needs to be taken into consideration when we are deciding whether we should be introducing a broader covering vaccination into South Africa. Of particular concern are the high-risk types 35, 39, 51, and 59, because these aren't covered by any available vaccine at the moment. So in terms of cervical cancer in South Africa, in 2020, it was diagnosed in 10,700 women, and this resulted in 5,800 deaths. It was the second leading cause of cancer in women, and it was the first most common cancer and cancer death in really young women. Oh, sorry, in young, I'm missing the female icon there. So first most common cancer and cancer death in females 15 to 44 years. And the age standardized rate was 35.3 per 1,000 women per year. Okay, so moving on to screening, which I know was covered in the first talk, but just quickly. Screening obviously aids in detecting precancerous cervical dysplasia and in the early diagnosis of cancer. So the current South African guidelines for cervical cancer screening for low-risk women are 3 times at 10-yearly intervals starting at the age of 30 years. And when we say low risk, we mean women who are asymptomatic, who are HIV negative, and who don't know their HPV status. High-risk women should be screened at the time of their diagnosis or at the time of knowing their risk at 3 yearly intervals or at annual intervals, and this is based on the screening results, and this is for the duration of the woman's life. High-risk women are those who are asymptomatic, HIV positive, those who are recipients of organs, those who have immunosuppressive diseases, and those who are on chronic immunosuppressive therapy. And then lastly, any symptomatic woman should receive screening at the time of symptoms and then follow up depending on their results. So with methods of screening, the 2017 Cervical Cancer Prevention and Control Policy recommends that cytology-based screening via pap smear be the method of choice in the short term. So this was in 2017. Liquid-based cytology and HPV-based DNA screening should then be phased in based on resource availability. And the aim is for liquid-based cytology and HPV-based screening tests to constitute 50% and 20% by 2020, and then 30 and 60% by the year 2030. So I know I was asking Shastra Bora about what is used at Charlotte, and she says that they're only using liquid-based cytology, but very intermittently is HPV screening done. So the reason that we have wanted to change to liquid-based and HPV-based screening is that liquid-based ensures a very good quality slide, which is a lot easier to interpret. But HPV screening should ultimately be recommended because it has a high negative predictive value, exactly what Trudy was saying. And actually, it's been demonstrated that the risk of developing cervical intraepithelial neoplasia stage 3 after a negative DNA test is almost zero within 10 years. So our screening uptake in South Africa really isn't great. So it's about 50%, which is better than what was presented in the first talk. But so the place I got my data from was from a national population-based survey, which was done in 2012. And this found that 52% of all women had ever had a pap smear. This particular image on your screens is from a study using data extracted from the NHLS, and that this reported between 2013 and 14 that the median coverage was 33%. And then women attending an integrated health screening clinic in Soweto reported that only 25% have ever had a pap smear, with only 50% of women over the age of 30 and 60% of women who were HIV positive. Okay, so there's 3 HPV vaccines currently available. So there's Cervarix, which targets HPV 16 and 18, which I've said are the most carcinogenic HPV types, and what's currently being used in the South African immunization program. Then there's Gardasil, which targets HPV 16 and 18, as well as 2 low-risk types, so 6 and 11, which are associated with genital warts and something called recurrent respiratory papillomatosis. And then there's Gardasil 9, which targets the same types as the quadrivalent, as well as 5 additional high-risk HPV types. Okay, so in South Africa, the school-based national HPV vaccination program was introduced in 2014. It targeted girls at 9 years or older. These were mostly in grade 4, and the Cervarix bivalent vaccine, which is a 2-dose schedule, is currently used. The vaccines are given 6 months apart within the academic calendar. So how well are we doing in this program? So it was pretty good in the beginning. So you can see the red line there. In 2014, 83% of all girls were vaccinated with the first dose, and then 65% in the green line in 2014 were given the second dose. Unfortunately, you can see these both have declined over the years. As of 2020, the cumulative proportion of all girls who had ever received at least 1 dose of the vaccine at any time was 75%, whilst 61% had completed the full 2-dose schedule. So data for the second dose in 2020, so that's the green line over there, we don't actually have data for the second dose yet, but the first dose, which was estimated at a dismal 3%, gives some kind of indication of what COVID-19 has done to the immunization program. So in order to try to minimize this effect, the South African National Advisory Group on Immunization recommended prioritizing girls in grade 5, most of whom would have missed their doses in 2020. And then I just wanted to note that the national coverage data doesn't include anyone or any girls from the private sector. So girls attending private schools do not receive the vaccine as part of the school-based program. And as there aren't any nationwide estimates of the vaccine coverage rates in the private school sector, someone did a cross-sectional Facebook survey conducted in 2018. and they found that only 19.4% had ever received at least one dose of the HPV vaccine. So it's even worse in the private sector. Okay, so what's new? What should we be considering? Okay, so to start, interestingly, South Africa is seeing infections secondary to one of the high-risk types, which is 35. Among women with African ancestry, HPV 35 is detected in approximately 10% of cervical cancer, compared to 2% of worldwide cases. Studies done particularly in sub-Saharan African populations have reported a prevalence of up to 40% amongst women with cervical dysplasia or cervical cancer. So these graphs are from a study which investigated the prevalence of distribution of high-risk genotypes. This was in 450 women with abnormal cervical lesions, who were then referred to an academic hospital in the Eastern Cape, and the study ran from 2018 to 2020. Okay, so in these graphs, the red bars represent a single type of HPV infection, black are multiple types of infections in the same woman, and then blue is the overall prevalence. So HPV 35 was the second most common high-risk type detected overall. Amongst women with cervical intraepithelial neoplasia stage 2, it was the third most dominant, whilst amongst women with stage 3, it was the second most dominant, and it was the fourth most common type in women with cervical cancer. So you can see that we really need to be considering it for inclusion in a vaccine that could be used in countries with high populations of women with African ancestry. Okay, so next, should we be considering the introduction of the non-avalent vaccine into the national program? This vaccination provides almost 100% protection against 5 additional high-risk HPV types, and this would protect against an estimated 90% of cervical cancer. So as mentioned earlier, several studies have shown that South Africa has a high prevalence of high-risk HPV types that are currently not covered by our bivalent vaccination. So changing to the 9-valent would therefore obviously give additional protection. But then the big question is, would it be cost effective to implement it into our national program? That's what government wants to know. So this study evaluated the cost effectiveness of all 3 vaccinations in girls from 9 to 14 years, and this is all from the South African healthcare system perspective. Vaccination costs were calculated based on WHO guidelines. Okay, so the ICER is the incremental cost effectiveness ratio, which is a summary measure representing the economic value of an intervention compared with the alternative or the existing intervention that we currently have, and it is calculated in South African rand. Okay, so just to orientate you on how cost effectiveness studies determine just this, an incremental cost effectiveness ratio is calculated by dividing the total costs, the difference in total costs, by the difference in the chosen measure of health outcome or effect. And this provides a ratio of extra cost per extra unit of health effect for the more expensive therapy versus the alternative or the existing. And the quality adjusted life years, or the QALYs, is used here as the measure of health effect. A QALY is equal to 1 year of life in perfect health, and they're calculated by estimating the years of life remaining for the patient following the particular intervention or treatment. Okay, so this figure shows the results of the study. So you can see in the first row that when compared to no vaccination, all vaccinations strategies dominate. When compared with the current bivalent vaccination with the new non-avalent strategy, you can see, let's go here. So you can see it increases the QALYs by 0.14 at a cost of 1,700 Rand, with an incremental cost ratio of 13,000 Rand. So what this means is that at the cost effectiveness, the probability of cost effectiveness at the South African willingness to pay threshold, so South Africa is willing to pay 22,000 Rand per QALY, it is then actually cost effective to implement this non-avalent vaccination with a probability of 90%. So that's great, it is cost effective, but the problem is that coming up with this initial money to introduce the new vaccine is often the greater barrier, even though it will be cost effective in the long term. Okay, and then the third thing to review are the guidelines on cervical screening. Currently, the South African screening policies excludes undiagnosed HIV positive women, which is especially worrying as the national peak of HIV infections occur in young women from the ages 15 to 24 years. It also excludes HIV negative women less than 30 years. Both of these populations have been found to have very high prevalence of high-risk HPV infection. So to illustrate this, a study which was done in a screening center in Soweto investigated high-risk infection, HIV, and cervical risk amongst women. Okay, so of the abnormal pap smears, just less than half were from very young women, 18 to 29 years old, of which all women with high-grade squamous intraepithelial lesions and 4/5 with low-grade were HIV negative and therefore would have been ineligible for screening if they were asymptomatic. Over half of the high-risk HPV infections were amongst younger women, with nearly 20% of 18 to 29-year-olds infected with either HPV 16 or 18. 2/3 of these high-risk infections were from HIV negative women, and a third were from women with normal pap smears. And they still remained, with high-risk infections. So current guidelines would have left out a large proportion of all these women with high-risk HPV infection. With evidence showing that HPV-based screening provides a 60 to 70% greater protection against invasive carcinomas compared to cytology, we really need to strive to implement this quicker than we are. But despite its promising performance, cost, logistics, technology, kind of administrative barriers are all challenges in implementing these things. So interestingly though, the Gene Expert, which is a PCR-based test, which we all know diagnoses TB, can actually be used to detect 15 high-risk types of HPV within 1 hour, and it can be performed in very resource restricted environments. And most clinics actually, well, a lot of healthcare facilities all around the country have access to the Gene Expert machine. So whilst currently it's quite expensive, it might make the implementation and testing more feasible in the future. Okay, so as mentioned earlier, the aim for South Africa is for liquid-based screening to constitute 30% and HPV-based screening to constitute 60%, all by the year 2030. So I couldn't find any recent statistics on which facilities have transitioned to HPV DNA screening, but the fact that Charlotte hasn't transitioned doesn't give me a lot of confidence for many centers, but I know the treaty did say that the Western Cape is a kind of a lot further along in this. Okay, and then lastly, just to chat about whether we should be giving 1 versus 2 vaccination doses. So the convening of the WHO Strategic Advisory Group of Experts on Immunization, or SAGE, in April of this year, evaluated whether evidence showing that a single dose schedule provided comparable efficacy to the 2 or 3 dose regimens. So actually, SAGE now recommends updating the dose schedules for HPV to 1 or 2 doses for girls 9 to 12 years old. But immunocompromised individuals, including those with HIV, should receive 3 doses if feasible, and if not, at least 2 doses, because there's limited evidence regarding the efficacy of a single dose in this population. Okay, so I'm coming to the end of my presentation. I just wanted to emphasize certain points for you to kind of consider and take home. So HPV infection and its complications causes a huge amount of morbidity and mortality in South Africa. We currently have access to a highly effective vaccine, but it doesn't protect against other frequent high-risk types found in South Africa. And so it seems we really should be moving to the non-avalent vaccine. We should be moving towards HPV DNA-based screening a lot more quickly than we are. And as our coverage for HPV vaccinations isn't optimal, especially for the second doses, should we be looking at changing it to a single dose? I think this is quite a difficult thing to decide or to say, because our population obviously has a high proportion of patients with HIV. And so will we then underdose a high proportion of undiagnosed HIV positive women? Or if women do know their status, will they then be required to disclose this at school to ensure an extra dose? And how would we ensure that those who are immunocompromised will receive an additional dose? So just things to think about. Thank you.